Just give me 1 second. So, good afternoon, everybody. Welcome to our October board of a meeting in public, not a public meeting. As you can see, I'm not Russell, I'm Julie Holder, Vice Chair, and we have apologies from Russell Hardy, Glenn Burley, Paul Capener and Anil Majithia. In terms of leading the board this afternoon, it will be myself in terms of chairing and Catherine as managing director. I just wanted to start by saying to give a huge recognition to staff working within the hospital every day, but particularly today. We have heard at the start of the day what huge pressure there is within the hospital, but also a particular shout out to our colleagues in ED who are coping with an awful lot of pressure, but also as a result of that, to provide some apologies to those patients who have been waiting a long time, but also waiting for beds. That leads me into what our discussion has been in a workshop forum earlier today, this morning, quite a long, lengthy discussion which followed on from two quite distressing patient stories. But what that allowed us to do is to work with a whole range of partners, which was really good to have so many partners in the room, giving a real focus on discharge and providing care closer to home, and through various initiatives that are already in place where things need to be improved, but also the opportunities that could arise from the community integrator programme. We also had some time with our Freedom to Speak Up colleagues and talked about our progress and the priorities in that area. With that, I'll just go into the formal agenda. So are we chorus, I think? Any new declarations of interest? Please raise a hand if there are, or around this particular agenda. No? Minutes of the public board held on the 3rd of September, are they a true record of the discussion? Any changes to be made? No, thank you. In terms of the action list, I think most actions are due in December or beyond. We've got confirmation that Freedom to Speak Up data is now being included. And Sarah, I think you've got a meeting in the calendar with Carol at UHCW. So we know that's being progressed as well. Any other matters arising? No, thank you. So we go straight into opening up with yourself, Catherine, taking Managing Director's report.
Thanks, Julie. Well, since we last met, Lord Darcy has published his report, which is a diagnostic into the state of the NHS. And Darcy highlights three factors behind the current condition of the NHS. The three factors that Darcy really picks out is a period of austerity in the 2010s, particularly impacting on capital funding and highlighting an £11.6 billion capital backlog, maintenance repairs, which makes productivity in the NHS difficult. In terms of also the uptake of digital capacity compared to the commercial sector, lags far behind other areas and other sectors, and then highlights the Lansley reforms in 2013 onwards, where the NHS was reconfigured, and notes that there was quite a lot of management capacity stripped out of the NHS at that time. Consequently, those factors together meant that by the time we got to the COVID pandemic, the NHS had a higher bed occupancy and fewer doctors and nurses than other similar economies, and consequently the NHS cancelled more elective activity, more appointments, more operations than other comparable health systems. And that leaves us today with the state of the challenge for the NHS and the very, very high backlog of care that patients are experiencing. So this effectively is a diagnostic. The future response to this is going to be in the form of the NHS 10-year plan, which is due to be published sometime in 2025. I think Darcy does highlight the importance of listening to the voice of patients and the voice of staff. And it's pleasing to see that there's no massive reorganisation of the NHS plan, but I think we can predict quite clearly the signals of what is going to be the shape of that plan, which is about moving from analogue to digital, from acute to community, and from sickness to prevention or wellness. And I think we will spend time as a board looking at how we get into the right shape to meet those challenges. They're not new challenges for the NHS, but it's really going to be how we set ourselves up to deal with those in the future. I also referenced the Community Recovery Service and the funding challenges that this is presenting for us as an organisation and for a wider challenge across Warwickshire. We've spent some time this morning, as you've said, talking about the community recovery, talking about out of hospital care, and the Community Recovery Service is essential for patients that are needing extra support at home. There has been a funding gap this year, and as a result, both Swift and George Eliot have agreed to underwrite this, but we've asked for some changes in year in terms of either taking costs out or an improvement in the service, because this is coming as another £0.5 million cost pressure to George Eliot, for which we have taken the money out of the winter funding, which you will come across later on in the agenda. Moving on to some good news, I wanted to really thank George Taylor Farron, Paula Quinn and Carla Johnson for their work around the Armed Forces Covenant. And I was delighted to be able to go with George to collect our Silver Award in the Employer Recognition Scheme. We signed the Armed Forces Covenant a year ago, or within a year, and to be able to get the recognition for the Silver Award so quickly is a testament to the hard work. This is being led by our staff for the benefit of staff and patients, and we were highly commended for already having workforce policies that they consider to be at a gold standard. And it's really encouraged us to push on to do more to support the armed forces, cadets, reservists and their families who have some different needs that we need to take into account. I also talk about Staff Appreciation Week. It is my favourite week of the year. As an executive team, we were delighted to be out and about, appreciating and valuing our staff, and we went to many areas and there's a few photos in there. I also really want to thank the Rapid Relief team for the support they gave to us by providing a free meal to our staff, and it was a brilliant day. The sun was shining, people were outside enjoying food and a chance to be together as a team, and it was brilliant to see the spirit of people taking food back to other people that couldn't leave their wards or areas caring for patients. But it's been so nice to really appreciate our staff who make this organisation what it is. And there was competition as well in terms of charity fundraising, and the George Eliot teams and many of the people on this call took part in a charity. It's a knockout versus Swift. Unfortunately, we didn't take home the spoils, but that was certainly Jenny's dancing certainly made up for that. I know she'd like me to highlight that in the public board. And then we move on to some updates from our great teams. So urgent and emergency care, Julie, you've already referenced them today. That team deals with an awful lot of pressure. They highlight the work they've been doing around recruitment and recruiting successfully to ED doctors, registered nurses and radiographers. They have also become an early adopter of the National Acuity Tool, which will help understand some of the needs within our resus areas. And they talk about introducing a cubby for some of our patients who have neurodiversity, and where noise and the busy waiting area can be quite distressing for people. So they are piloting that as a way of providing a quieter environment for people who are waiting. And that's been made possible thanks to the work of the George Eliot Charity and the League of Friends. And then finally, just wanted to highlight some of the work that has been done around the dementia framework and strategy. There's quite a lot of detail that I won't go into board here, but I do want to highlight some of the important work around the relaunch of John's campaign, meaning that patients can have their family members with them to support them. We know that patients with dementia, their loved ones know more about them than we do, and it's really great to be able to make sure that we get involved the whole family in the care of the patient. And there's some information in there about how we prevent people with dementia coming into hospital, how we train our staff to deliver the best care, and how we collect the right data to support excellent management of patients with dementia. Thank you very much, Julie. I'm happy to take any questions.
Thank you very much, Catherine. Questions to Catherine? I think the way in which you've presented that has been really helpful, Catherine. I suppose just a couple of things from me. I think it's great that we have a very clear mission-led approach, hopefully from government. The planning guidance will come out before the 10-year plan, and let's hope that some of that comes through into the planning guidance as well. And I think it's just also we need to acknowledge there's a lot of things to acknowledge in that your report there about the good work, and the Staff Appreciation Week is great, but we need to do that every single day and remember what a great job that our staff do. So thank you for that. Okay, we move on to mid-year review. Catherine and Jenny.
So I'll take this. Jenny's done all the hard work of putting this together, but I think the paper can be largely taken as read, but there are a couple of areas that I would really just like to highlight to you. In terms of reducing vacancies, been really successful. You can see this in the metrics. And what I want to highlight in this is the flexible rostering. This is one of our big moves to become a more flexible employer. And we've now implemented self-team rostering into 12 clinical areas, with more coming on stream this autumn. In terms of reducing waiting times, we've heard as a board about the work with Deep Medical and our volunteers to reduce the number of DNAs so that we can use those appointments, so do not attend, for patients that need our services and to see more new patients. And we heard and will see in the Improvement Board report of the excellent work that has been done by our theatre teams and surgical teams to improve our elective productivity. And that's really working well, and we're starting to see measurable impact of that. In terms of reducing bed occupancy, you'll see when we get onto the BAF and our discussion this morning, we are not where we want to be on that. But I do want to highlight the work about the reconfiguration of the surgical assessment unit that took place at the beginning of this financial year. And we have already seen a reduction in length of stay in surgical patients. So that area is working well. In prevention, there's some great work going on in the community with community vaccinators that have really materially improved the rates of vaccinations against pregnant women in some of our more deprived communities. And we heard today about the work we're doing with our place partners and our community partners around the community integrator. For our green champions, this is a very popular role, and we're already up to over 50 people who are green champions in the organisation. But our staff are really driving change across this agenda, and it's really rewarding to see that. In terms of the digital work, we have successfully rolled out the iBox across our wards and signed the contract for the electronic patient record, which is now underway for the implementation. And then finally, in the health inequalities, we've already touched on the dementia strategy, but it'd be important to point out the work of the community heart failure bus, bringing excellent expert management of heart failure out into our community. So there's a lot to celebrate and a lot more that isn't even in this report. But I hope you can read this in the context of our BAF later, because there's a very direct correlation between the progress against our objectives and our assurance in the BAF.
Thank you again, Catherine, and thanks, Jenny, for the report. Comments, questions? Jenny?
Well, not really a comment, but just to pick up on the health inequalities piece, I'd just like to make the reference to the fact that we know health inequalities is going to feature really highly in future plans within the NHS, and there's also been a recent report out from the King's Fund in terms of issues and recommendations, and we've already done a lot of work around our health inequalities approach within the organisation, that as a consequence of the fact that we've had health inequalities as a firm objective. And if you remember, we did the work with the board around looking at health inequalities as a board, and we've set up an enabling working group that's really driving that forward. And there's a lot of work in our place reports as you come through around health inequalities. So just to add to what Catherine said, I think that health inequalities work is in a really, really good space, both in terms of strategy and planning, but also delivery as well. So we're in a good place to be already responding to what will come through on that report.
Thank you, Jenny, and thanks. It was a really good workshop that we had around inequalities, and was very proud to actually hear and see what we've got. I'll bring in Rosie, and then I've just got a question or a comment, really. Rosie.
Thanks for that report. It's really clear and nice to read it in such a concise format. I was just wondering if you could tell me a bit more about the Heart Health Bus, how that works, and how you'll know that you're getting to the right groups of people.
Do you want me to pick that up, Catherine? Yeah. Okay. So it's an initiative with our teams. It was their idea. They came forward and they'd already identified that there were certain client groups that they weren't reaching out to. And we've worked in terms of looking at the data and where we need to go. We've overlaid that with our health inequalities data in terms of our particular communities, etc. We've worked in partnership with our PCNs and with other partners in terms of where we can park the bus and where it needs to go, etc. And I mean, I could go on forever really, because we're also looking at it in terms of how we can link it with other services, so we can offer more than just the heart failure. So it's like an every contact count approach. So that's what we've been doing, and obviously they're monitoring the reach that they have and the impact that they have, because it's part of our health inequalities funded initiatives as well. So the data, it's data driven, it's clinically led, and it's partner collaboration throughout.
Thank you.
Thanks, Jenny. Thanks, Rosie. It was leading on, that sort of leads into my comments. So I thought it was a very concise, easy to read report and very useful in terms of a public board report. I suppose for me, there was a little bit about, there's a bit of a mixture. There are a few outcomes in here, but outcomes aren't actually captured within this report. So for example, around that particular launch of the Heart Health Bus, it might be good for me, I think, to hear how many people have we contacted, and we've seen that information. I think I don't want to make the report any much more complex, but if we can capture outcomes, I think that would be really good. And the implication, and we heard this morning, of actually fully implementing iBox is really important in terms of discharge, and so an early planning of discharge. So just something in future reports that allows us to just capture those outcomes. Jenny?
Yeah, no, that's absolutely fine, because each of our objective has got some form of data capture or key performance indicator, so we'll be monitoring those. But also I just wanted to say, for some of those other things, we've got case studies that we're developing and are part of our reporting processes, so we can always bring those forward potentially. For example, if you wanted a specific discussion through when we do some of our presentations and our good news stories, so we can provide those.
Okay, don't want to overcomplicate the presentation though. Okay, thank you very much. And so any other questions? Happy to move on. We're receiving that report, and I think it's over. Is Robin, are you back with us, Robin?
I'm back with you now, Julie.
Good.
Okay, I'll take it away on this report then. So this is the report on our winter plan. When I say ours, that's a Warwickshire North winter plan. It's in the same way as we did last year, we've worked together with our system partners across Warwickshire North as a place to look at what we did last year, a review of what worked well, what didn't work so well, with a view to influencing the things we need to do this year to help us to manage the demands of the winter period. So it's worth noting that there is a separation of the funding streams for primary care this year as well. So primary care, as part of place, have been given an allocation of funding that is being used within primary care to fund further initiatives to support winter and help with admission avoidance, particularly, and keeping patients safe and well in the community. That's why you don't see that element within these actions or within these items on this report. So in essence, the financial envelope is in the report, just over £1.1 million. And as Catherine's referenced, the discussion around funding the Community Recovery Service is the primary reason why this report is coming to board so late. We started these conversations with our system partners about our winter plan for 24-25 back in March, at the end of last winter. And so it feels as though this is quite a late report coming to board, but the delay has been around ensuring that we're clear on what's happening around the funding of the Community Recovery Service. And as Catherine said, as part of her update, the decision was made that just over £500,000 would be allocated to the continuation of the Community Recovery Service from the winter plan funding. Therefore, our teams had to go through and identify, out of the schemes that they were looking to put in place this winter, they had to prioritise those schemes. And so in the paper, it does demonstrate or show the schemes that effectively made the cut and the schemes that were removed. And you can see there were around about £500,000 worth of schemes that were removed. And effectively that made way for the funding of the Community Recovery Programme. So, Julia, I'm happy to take any questions from anybody.
Yeah, okay, thanks very much. And we're being asked to approve this report. So yes. Questions, please, and observations. Catherine.
Well, mine's merely to remind the board that what we would have liked to do is put some money in against opening extra capacity this winter. We were unable to do that with the original allocation, and as Robin said, it's been squeezed a little further. So we know that is a significant risk to us, and then also not being able to invest as we did last year. So this is in fact basically half of what we had last year to invest now. That does pose challenges for our teams in terms of managing what we know will be an increase during the winter months.
I think we need to note that as a risk. Thank you, Catherine. Jackie?
Thank you. Yes, thanks, Robin, for the report. I was going to make a similar point to Catherine. There are risks, I think, to the removing some of the items that we've removed, in particular things like the private ambulance and also pharmacy, because we know that those are two areas that can cause delay in terms of discharge. So I suppose we should just note that there would be risk to the patient flow.
Thank you, Jackie. Robin?
Yeah, absolutely right, Jackie, to raise that, and Catherine, the risks, there are always risks associated with winter and with any of these schemes and others that were not taken forward from last year. So we, as part of the process, the next step for this would be that a more detailed paper will come through Trust Management Board for discussion. So that is where those risks will be documented clearly, and that will also cover some of the work that we discussed this morning in terms of our community partner support and our system partner support with their services, as well as to collectively where those risks sit. So that the detail of that will come forward through Trust Management Board, just so the board are aware that is being monitored.
Okay, thanks very much. I think I would puts SDEC into that as well, because we heard this morning just how important that SDEC was in terms of our discharge arrangements. We also talked this morning, it was something that Sarah picked up, was around a lot of this money is looking to be allocated to medical consultants. And you made the point, I think, Robin, that this is about improving, this is about being consultant led as opposed to consultant delivered. Can you just, or implemented, could you just talk about that before we go on to actually approve the report?
Yeah, of course. This effectively what we do. This is sort of, I suppose, in a way, the tip of the iceberg. This is where we need to put extra resource in, to particularly around consultant job plans, etc., in order to be able to put that additional resource in. What we also do beneath this with all of the directorate teams is we look to work through an alignment of our existing resource. So there will be members of our team that work differently within their teams. For example, we're having conversations on how the frailty team will work differently as a good example. And that would include physicians associates, senior pharmacists, therapists, and advanced nurse practitioners to work differently to, therefore, to make the most of their skill sets as well as just additional medical resource going in.
Thanks very much for the clarification. Okay, I think there's an action there about if you can come back to us after TMB discussion about how those risks are being handled because of taking out that extra money. Are we, or taking out those particular items, are we happy to approve? If you're not happy to approve, can you raise your hand? Okay, thank you. Report is approved. And then we move on now to sustainability. And I think, Jenny, this is you.
Yeah, and I've also got joined by Sean, who I think is on your page 2 of your, if you've got your gallery like mine is. So thank you, Sean, for joining us. So I will take the paper as read, but just a couple of highlights that I would like to just point out to you. In terms of on the executive summary, you'll see that we continue to have moved forward with delivering activities, and we've seen an increase in completed actions. We have some actions that are being mitigated with specific action plans, but they're all in progress. And just a couple of highlights to pull out with me again. Catherine's already mentioned it. We continue to try and drive our number of green champions up. We've now got 53, which is up from 41. We're still trying to target 100. And we did also include our green champions as part of our appreciation, writing out to them to thank them for all their efforts during Appreciation Week. You can see that we, despite our footprint of an organisation increasing, that we are maintaining and reducing our carbon footprint, which is good to see. And we've included our dashboard, which we're continuing to develop in terms of indicating where we are on some of the key metrics that we're currently monitoring ourselves on. The other thing I'd like to just pull out for your attention is that we've got a number of specific sort of communication actions this month, in October, so it's quite a busy month for sustainability for our communications work. And also to say that we've put 2 projects through for the green teams, which is really great. So we've got more initiatives coming on stream. The appendix gives you the date up to the end of August as we took this paper through September's TMB. So there are some activities that we did in September which aren't reported on here, but we continue to be very busy from sustainability point of view, and you can see the progress that's being delivered. Sean, is there anything you wanted to add?
Noting that the next round of SELIX will be coming forward soon as well for trusts to open bids for, so that's a very key metric for us for future green planning.
Thank you very much.
Thank you very much, and thanks for your work as well, Sean. Questions? Jackie.
Thank you. Thanks, Jenny. I suppose it's more of a comment than a question. And I think it's good to see that we're making use of technology to help us with our green agenda. And there's quite a few instances in the report where we can see that they're having an impact on the service for patients. So well done to the team.
And I probably ought to do a big shout out as well, because we had an excellent example of how one of our directorates is embedding sustainability within all that they do through our CSS team, and we're taking that learning into discussions with all the directorates. So it's definitely embedded in our models of care.
Thank you. Thanks for that. Again, I really like the report, the format of the report, easy to read, and certainly from a public board perspective. My one question is about where there is required management activity. There a lot under estates and facilities. Can you just explain a little bit more around why?
Yeah, so I'll start off, and then I'll also draw on Sean's experience. So a number of actions were initially put into the green plan. As you can appreciate, as some go forward, the dates slightly change, or some were contingent on the funding for the Salix bid, for example, as well. So some of those are amber at the moment because they are related to resourcing in terms of that bidding process, and we are going forward in terms of putting a future bid in, and we have done a review of the recommendations from our previous bid. But Sean, anything to add to that?
I think it's also worth noting that the trust are halfway through a 15-year CHP contract, which essentially takes 90% of our gas consumption. So we are halfway through a guaranteed savings contract currently that we've got to see the end of before estates can start seeing some good achievements. But ultimately, it's also based on the Salix funding too. Okay,
that's really important to note. Thank you. Thanks very much. And we're happy to receive and note that report. Thank you both. And we move on to the quality part of our agenda. And first of all, with yourself, Natalie, on safe nursing, midwifery and allied health professional staffing levels.
Thank you, Chair. And I'll take the report as read, and the points that I'd just like to draw the board's attention to. Our recruitment progress continues through the majority of the domestic pipeline, with a concerted effort in the last few months and going forward until December on healthcare support workers, because we have had and seen our biggest vacancy gap and over that group of staff. And we have welcomed 20 members of new to the team this month, and we're continuing on the larger cohorts in the next few months as well to reduce that vacancy gap that we know we have there. The remainder of our teams are working and continuing with that recruitment, as I mentioned, and we're looking at that trajectory over the next 3 to 4 months to be able to reduce our vacancy gap, and that's highlighted in the paper. We're continuing to reduce the amount of temporary spend on staffing, and particularly from our agency point of view. Our reduction in NHS bank is a little bit slower than we would have liked, but there are some main drivers towards this. Obviously, the safety factor coming first, and the recruitment trajectory into the vacancies, but also the extra capacity that we have open, and those patients that are in the extra temporary space that we deem to be boarding at the moment. We ensure that we have the safe staffing levels around that. And on that note, I just want to draw to the attention that we have had 0 harms reported due to any staffing concerns, and that has been maintained, and they're the focus of what we do. So the main points: recruitment, retention, and the continuation of reducing our temporary staffing. Happy to take any questions.
Thank you. Thanks, Natalie. And this is looked at in detail by Quality Committee. Any questions? Sorry, my phone was ringing. Just turn it off. Any questions or observations? Jackie?
Thank you. Yes. Thank you, Natalie, for the very clear report. I did have a question regarding boarding, because it says in the report we've got 67 episodes and 55 patients. So does that mean that we've got some patients who've been moved more than once, or boarded more than once?
It will be the period that we measure it over, Jackie. So our aim is that no patient would be boarded for a longer duration. we have on occasion that has slipped into the 2 days or over the 24 hours rather than, so it's counted into the next day. So we're counting the days rather than the number of individual patients. That's why there's the difference.
Thank you.
Thanks very much. And I think we can see that there's significant assurance around everything that's in place to ensure safe staffing. I suppose as the day's very cold today for me, I don't know about others, but I just wondered where your main concerns were, Natalie, as we start to go into that dreaded winter period, albeit, yeah, I know it feels like winter in the hospital today.
It does, and I think it's the sustained pressure, Julie, that is my concern, and making sure that we are looking after the well-being of our staff. You'll notice in the paper, and I haven't drawn that out this time, but the number of moves we have to make of staff to ensure the safety does have an effect on people when they're being asked to move, but that is reducing and becoming less and less as we have improved the recruitment. So it's maintaining that morale, maintaining their well-being, and I think most important it's the communication on what we're doing, why we're doing it, and how they support each other. The George Eliot staffing team are absolutely incredible when the pressure is as it is today, and they will support each other, and it's particularly about telling them that. And being able for them to be able to speak up to us when they're feeling that the safety element is not being recognised. And we have a daily huddle, staffing huddle, to particularly ensure that we're drawing any of that out. So I think it's just it is the increased pressure. And always my concern is the amount of boarding that we have to do, making sure that we've risk assessed for those patients properly, that we're still maintaining their safety, and that we can get them out of that extra temporary space and into the capacity that we have open in a timely manner.
Thank you, Natalie. I think it goes back to, I said we spoke about freedom to speak up, and, really encourage people if they are feeling uncomfortable, for any staff that listen to this or listening now, to feel comfortable to speak up. But that continued appreciation and wellbeing offer is just so important, to continue to say thank you. Doing a great job under great pressure. Thank you. Okay, so now we're going to bring in Lorraine, perinatal quality and safety report.
Thank you, Chair. So I'm going to take the report as read and just pick out a few highlights, and this is reporting for the month of August. So we saw a burst down in month from July, which was an extremely busy month, so that just meant that our midwife to birth ratio was back where it should be at 1 to 23, and we had 100% of one-to-one care in labour. We had no serious incidents declared, we had no stillbirths or neonatal deaths, and that meant that our rolling rates of stillbirths and neonatal deaths are way below the national average. Our training is an area that we're doing extra work around, our mandatory training, particularly with our doctors. Particularly we have new starters in August, so that we always know that our compliance goes down slightly, but they are all booked on for training, so that is really good to see. It was really pleasing to see that we confirmed that our Saving Babies Life compliance is at 94%, and I always say that, but that last 6% will be quite difficult for us to achieve because some of those things are outside of our remit, but we're working really hard, and we have our next assessment next month. We're really working hard on the CNST compliance for year 6, and you'll see in the report we've broken that down so you can actually see where we're at and where those areas that we're working on to achieve full compliance, but we do feel we're on track for that. The reporting period ends December. So it's getting close now and doing lots of work around that. We have our LMNS Insight visit next week to review our compliance with 3-year delivery plan. And again, that seems to be on track, but we're interested to see how they assess us when they come and visit. So we're looking forward to working on them. Our work around our massive septic hemorrhage is going well. Although our rates are still slightly above the national average, they have been consistently stable and reduced in the last couple of months, which is pleasing to see, but that work will continue. And really pleasing that Theatre 1 now is open, so we have our fully functioning Theatre 1 and Theatre 2, and we are turning our room 4 that was converted into a temporary theatre back into a labour room now, so that's really pleasing to see. So those are the main highlights I wanted to pull out of the report. Happy to take any questions.
Thank you, Lorraine. Thank you. questions, observations? Natalie and then Catherine.
Not a question, just I think Lorraine occasionally downplays the fantastic work that is taking place to be able to get that up to the 94% and working on the NST, and particularly with our safety record and the continuing to be under the national benchmark for the stillbirth, etc. So just a huge shout out to the whole of the maternity team on keep up the great work.
Thank you.
Absolutely. I think on behalf of the board, not just from yourself, Natalie, absolutely. Thanks, Lorraine. Well, pass that on to the team, the whole team.
Thank you, certainly will do.
Catherine.
Yes, mine's on a similar theme. I think as a board, we can take a lot of assurance from Lorraine's report, because these are measurable things. And as Natalie says, they are not easy to achieve. But whether it's the stillbirth rate, the saving babies' lives, the CNST, there are measurable improvements that you can see. And Lorraine, I don't know if I've told you, I think I've told everybody else that I bumped into the regional chief nurse for the Midlands the other day, who was looking worried about maternity in general, but wanted to say that she wasn't worried about maternity at George Eliot. And I think that's a testament to the amount of work and, as we say, the things that we can see and measure in this report. So thank you very much.
Thank you, Catherine. I'll certainly share that with the team. It's the team have done a lot of hard work, but it's keeping it going is the main thing.
I think it's really important because there's continued press around this, and obviously pressure on other colleagues in other trusts as well. But to be able to be recognised in that way is really, really good. So thank you. Okay, we note that report and we move on. Back to you, Natalie. Inpatient satisfaction survey results.
Thank you, Chair. I'll take the report as read. It is a very short report, but just to provide that assurance to the board and to the public, the details of the CQC and all of the results for the inpatient survey are dealt with in depth through our patient care collaborative, and also then through the Quality Assurance Committee. As you can hopefully appreciate, there will be and there are lots of improvement and action plans that the directorates work upon, because they can break things down into their own directorates and what we need to focus on. So I suppose very in a brief summary, 42% of all of those patients that were eligible to complete the survey did so and responded. 95% of those described themselves as white, 65% were older than 66, and 84% described themselves as having a long-term condition. And all of these statistics and facts and demographics are broken down in the CQC report, and we look at those and take those into account when we're planning those. So we have, for every single one of the sections, we are in the middle of the pack. We're the same as the majority of other organisations. We haven't got any of our responses that are in the top quartile in the best, and we haven't got any in the worst section either. Saying that, being in the middle is not where we want to be. We are aiming for improving on those scores and looking very specifically at some areas of improvement which are included within the report. One of those areas that you'll see in the report is being prevented from sleeping. It is a new question, so it looks like it's a very low mark on that, but when you could take into consideration what I've just said about all of our responses are in the middle from a national point of view, but it is a new question. It does include not only noise at night, which was the previous question that was asked of patients. It now includes things like the environment, that being asked to move, or patients being admitted in the middle of the night as well. So it takes into consideration more factors. We'll be looking quite closely at that one. Our focus, and has been for the last few years, is with regards to our discharge processes, our communication levels with our patients, families and their carers, and what information that we are giving. Because we have declined in that area from our own internal mechanisms from last year. So we need to look a little bit more about how we're doing that, what's happening, that we're not giving a clear steer on the discharge process for our patients. And one of the areas that I think can be a quick win is with regards to the feedback on their care. The way that question is framed, we need to be able to very clearly demonstrate to our patients that it is a patient-centred care, that we are aiming for, to ask them about the quality of their care and any improvements in their satisfaction. And I don't think that we necessarily do that as clearly as we could. So they're the main focus of our areas that we're looking on. I also wanted to just thank the Patient Forum for all of their support, because this survey takes place, as you know, once a year. But in the interim, our Patient Forum do a number of surveys for us. If we've got an area of concern or an area of focus, or if we've had some soft intelligence around a subject, then the Patient Forum will go out and do a survey for us. And recently we have asked them to go and speak to the patients that are in the extra capacity, that are in the corridor or boarding on the wards, and they have completed that report for us and given us some actions from that to be able to improve. So we are constantly listening to the feedback. Our patient feedback is incredibly important to us, and we act upon those. So we'll be focusing on these areas, as I've said, and I think it's also just to mention at this point that, as you're aware, each month we have Friends and Family Test, where we get that satisfaction. Our current provider has given us notice, so we're at a tender process to find another provider, and in the interim we have solutions to be able to still continue to get that data, but it's important to us to make sure that we have other focuses as well. We were able to get the information from other areas, because we might see a reduction in the response rate, so we need to focus on this to ensure that we don't lose any of that valuable information. I'm happy to take any questions.
Thanks very much, Natalie, and thanks to Patient Forum, because it is important that we don't just rely on this one snapshot. It is, and friends and family as well, but it's great Patient Forum are helping us. Questions and observations to Natalie? Catherine?
I think there's two things that I'd just like to draw out of this report. Those of us who were in the board workshop this morning heard the experience of two patient stories around discharge, and I think for all of us just highlighted how complex discharge can be from hospital for many patients. And we should hear what we heard this morning and then hear this again. It's the same thing being told to us, that discharge is complex. People need clarity around that. And at the moment, we know this is an area in which we could improve. The second thing I'd just like to pick out is these areas of celebration about being treated with respect, dignity and kindness, and the privacy. We have heard already about boarding in the hospital, about overcrowding in the emergency department, and to see those two compassionate care things come out as areas of excellence, I think is a testament to the way our staff deliver care, both in the emergency department and on wards when people are being cared for in spaces that we would not normally care for patients. So I think that's a testament to our staff, but I think we really have to hear that message we're hearing around discharges, that we need to do better than we are doing at the moment.
Thank you for summarising that, Catherine. And I think we have had a very good discussion around discharge. The new one for me about being prevented from sleeping is really important. I guess for me, Natalie, given that there are so many things to celebrate around respect and dignity and cleanliness and confidence, I don't quite understand the definition of the question around feedback on care. It seems a bit contra to me.
I think you're right, Julie, and I think it is the way it's framed in the inpatients. If you look, and again, because we're in line with the majority of hospitals. I think it's particularly the way it's framed in the inpatient survey. I don't think it is that we are not asking, we're not listening, we're not talking to our patients. I think it's the framing of the question. I think it actually says something along the lines of, were you asked about the quality of your care? Now, we wouldn't necessarily ask it in that way. So I think it's around the question.
It's a very literal question, isn't it, potentially? Okay. Thank you very much. I think we're happy to receive the assurance around that and how it's being monitored, and it will come back through Quality Committee. Thank you. So into the performance section of the report of the afternoon, and we start with Catherine, Integrated Performance Report.
Thank you. Sorry, just getting myself off mute. So this is the report for August, and all things considered, from an emergency perspective, August was what you could consider perhaps a better month. There were lower number of attendances to the emergency department, and consequently we had a lower number of 12-hour breaches, 56 in this month, still too many, but it was 133 the month before. A&E performance in terms of the 4-hour target stayed relatively similar at 74% to previous months. But what I just want to highlight, it was in the nursing acuity report, is on this good month in August, we were on an internal level 4, so boarding patients, for 15 out of 31 days. So this is our best month of the year in terms of our number of people attending and our performance in the emergency pathway in terms of delays for patient care. But in 15 out of 31 of those days, we still had additional patients on our ward. So even during the peak of summer and when we would all be out eating an ice cream, it was still very, very challenging conditions in terms of the capacity that we've got for patients and our bed occupancy. That was helped during the month by the fact that we saw a reduction in our medically fit for discharge numbers during the month of August, and it was around 40 for most of the time. It's been back up since in September to 60 and was 50 yesterday. So that's why we spent such a long time looking at discharge out of hospital and bed occupancy this morning. In terms of our cancer performance, we have maintained or almost maintained the cancer performance that has been improving over the last few months. The 62-day referral to treatment target improved again in July to 67.9%, bringing us within a whisker of the 70% target. And our number of patients waiting over 62 days was 34, which is the lowest that it has been for some time. This 28-day referral to diagnosis target was just shy of the 77% target, but we seem to be maintaining that, and it's really important that we continue that focus on that. In terms of quality, I just want to draw your attention to some of our hospital-acquired infections. The one to watch really is the C. difficile infection rate, which at this point in the year, 21 cases identified compared to a target of 34 for the year. So ahead of where we would like to be ideally in the year. A bit better for things like Klebsiella and E. coli, but certainly a lot of work going into that. And you will see our mortality rates remain within the expected range for HSMR and SHIMI. We are an outlier for weekend mortality, and the Quality Assurance Committee spent a bit of time looking at some of the factors that lie behind that and the work that is going on to understand that better and reduce that. I do want to say thank you to our estates team for the continued work they are doing around our ward refurbishment programme. And we are now on to the final ward that we're planning to refurbish this year, which is Felix Holt, and the teams that have moved around the hospital whilst we undertake that work. And again, Natalie's report highlights the work that's been going on about assessment and accreditation of the wards. and 6 of our wards have now had their full assessment and feedback. And this is really intended to drive up quality in our wards. But what's so nice to see is the pride in which ward managers, ward teams are receiving this feedback and wanting to make improvements in care, which directly relates to the last report about patient satisfaction. In terms of our elective performance, so we've set ourselves a really ambitious target for our elective recovery, and in August we didn't quite get there. Now some of that was understood due to annual leave and what have you, but we hope to see that improve. We were hitting 130% relatively consistently in the first 3 months of the year. We haven't seen that bounce back quite as well in day cases and first appointments. Our elective work is going really well at about 160% of the 1920 baseline. But what I do want to celebrate is that in September, I know this is August data, but let's just go straight to September because we know the answer. The target was to eliminate 65 weeks in the organisation by the end of September. And Robin and I were on tenterhooks yesterday as the last 3 patients who had been waiting 65 weeks were treated yesterday. So a huge thank you particularly to our surgical teams, because that has been quite tricky to manage that. And we've had leaks in theatres with all the water that we've had recently and other challenges. But our teams have worked really hard to make sure that as this organisation, we have managed to hit that target of eliminating 65 weeks by the end of September. So where does that leave us on the money? Well, challenging, I think, is the word that we would use for that. In August, we are broadly online with our plan for the year. We delivered a £0.5 million surplus in month, taking us to a year's deficit position, which is broadly in line with the plan of 3 million. But we've delivered that through non-recurrent means in terms of balance sheet flexibility, interest on cash balances, and delays in depreciation costs for some of the new wards and the CDC, and holding some vacancies in the corporate directorates. But the run rate is £1 million higher than we would like it to be, and than we need it to be if we are to meet our financial plan for the year. So there is a lot of work. We've identified almost all of the cost productivity improvement programme, but there's still a gap and teams are working hard to close that. And we've also had a workshop in September with the directorate teams, the corporate teams, looking at the additional steps that we are going to need to take in order to try and stay in line with our financial plan. As you know, from a system perspective, the system is in a concern to NHS England because of the current deficit in year. So we are not yet subject to any additional scrutiny, but there's certainly a lot of noise around the additional scrutiny. And what we are trying to do as an organisation is to take those steps before someone tells us to take those steps and try and do the right things, because we know that our plan is built on treating as many patients as we can and reducing as much temporary spend in our staff, and making sure that we have recruited, value and retain our own staff rather than a reliance on expensive and often not as good quality agency staff. And we've done brilliantly at eliminating or reducing agency staff. We've just got to do a bit more to take out that bank spend as we increase our substantive spend. So that's broadly where we are. I am happy to take any questions about any of it.
Thanks, Catherine. Questions to Catherine? I think ably summarised, Catherine, and just to remind members of the public that there is a lot of scrutiny that happens during Quality and Safety Committee, but also with our finance and performance FPE arrangements as well. I just want to make sure that the public notes that there is a public guidance pack available on the website as well, because it's sometimes quite difficult to understand exactly what's going on. I think for me, Catherine, what it absolutely showed is the importance of that discharge discussion today and how that's critical in terms of then elective care. What that in being able to actually meet those elective targets, the quality of care that we can give, and ultimately then the financial position as well. So I'm just so pleased that we've been able to work with partners on that today to start to even get better flow within the hospital. Catherine.
Yeah, I just wanted to sort of say that after that discussion this morning, the executive team were having their very thought-provoking having a discussion, and Hack pointed out what is obvious is that when we do the right care in the right place, it's also the most affordable care. And at the moment, we're driving costs within our organisation and across the system because we haven't quite got that right. So there's not only a quality reason to get this right for patients avoiding an overcrowded emergency department or deconditioning. There's not only a performance element so that the IPR could look a bit better than it does, but there's a financial reason to do this as well. So doing the right thing is doing the cost-effective thing as well. So just wanted to make that point.
Absolutely, thank you. Okay, and speaking of Hack, we'll now hand over to Hack for the capital report.
Thank you. Nice segue to me. So we've got a capital programme of £8.5 million, but as previously reported, we're continuing to hold back £1.2 million, and that's part of the system-wide risk share arrangement in relation to UHCW's EPR not being fully funded from a capital perspective. But we continue to work with our system partners to bid for additional funding to be able to plug that gap. We were able to do that last year, so hopefully something will come up to help us with that this year as well. So working through that. But in terms of looking at what we've spent so far, so we've spent £3 million. That's £1 million behind our plan. That's not really a concern, because when we do our financial plan, that's before all the detailed operational planning has been worked up. So we have to make quite a number of assumptions. So the underspend at the moment is related to the ward refurbishment, where we assumed a different timescale. So it's not that the ward refurbishment is running behind track, it's just that the detailed plan that then turned out to be a slightly different timescale. So as Catherine said earlier on, the ward refurbishment is due to complete at the end of October, so that's not an issue. And similarly with the lease for Bayton Road, which is the other big one here, we've got the underspend. It's just that the lease agreement has taken a bit longer to sort out than we originally assumed in the plan. So there's no issues really in regards to any of those areas that we're underspending on at the moment. And just coming to our kind of major project this year, which is a mortuary extension, the timescales have slipped slightly on that one, but we still do expect to complete that within this financial year. And in terms of other major projects, we have bid for additional £3.5 million of capital funding for an extension to our resus area within the emergency department. We're being told at the moment that we won't hear until the end of October, and that will potentially give us a problem in terms of trying to complete the project within this financial year. But as usual, we will find a way. It's not like we haven't been here before. Funding coming down nationally doesn't usually come late, and we've, I think, become quite adept at working our way around that, so we will manage that. And finally, there have been a number of requests in year from directorates to make changes to the capital programme. These have all been through the capital management group and all agreed by Trust Management Board, and they're set out in detail here for the board's benefit. So in summary, we expect to deliver the capital programme, and we continue to work with system partners to address the shortfall in relation to UHCW's EPR risk. I'll take any comments or questions.
Thanks very much, Hack. Any comments or questions? I think it's really good that you were able to give us that additional assurance about potential slippage, so thank you. Any other questions? Thank you. And again, we receive and note that report, and staying with you on referral to treatment and the tracking list update.
Right, so it's quite a technical paper, so I'll try and set it into context without going into too much of the detail, but happy to take any questions on the detail. So the paper sets out issues with the data quality of the what's called the RTT PTL, and explain in a little while what that means. And it also sets out the actions we're taking to address those issues and the current progress against those actions. So the RTT PTL, in its simplest terms, is the waiting list for those patients that have been referred to us in line with the National Referral to Treatment Pathway criteria. So the fundamental issue that we've got with the waiting list is that not all patients are appearing on the waiting list. And the issue has arisen due to a number of factors, including some issues dating way back to when Lorenzo was originally implemented. So this is related to data migration, data quality issues when Lorenzo was originally implemented. So that's been exacerbated by the way the waiting list report is produced from Lorenzo. And there's also some issues with human error as well, because the RTT pathway is one of the most complex processes that we have to manage, and some really complex rules around this. So these issues mean that the number of patients appearing as waiting on Lorenzo, which is our computer system, are significantly higher than those on our waiting list, and we know that's not correct. But despite the issues with data quality of the waiting list, we are assured that patients referred to the trust are being seen and treated, as we have other mechanisms in place to make sure that we are picking up all the patients that are being referred to us. And the validation we've done to date, the data validation we've done to date has confirmed that as well. So we have got some secondary assurance around that as well, because we haven't found any patients yet that were actually had not been picked up through those other mechanisms. So we've established a project which is led by Laura, who's joined the meeting, who will help me with any questions, because I say this is quite technical and I'm certainly not an expert at it. So Laura's leading a project, and we've got some governance around the project, around reporting fortnightly into Trust Management Board and oversight by Audit Committee as well. We're using a methodology that I've used previously, and it's also a methodology that NHS had supported when I used it previously, so we know it's a robust methodology, and we made good progress to date in validating the data, and to date we've added just over 1,100 patients to the waiting list as a direct result of this project, and that needs to be seen in the context of just over 17,500 patients on our waiting list at the end of August. So we're on track to have the new RTT PTL up and running by December, but it will take a little bit longer to get the training plan in place, as we need to recruit into the Deputy Patient Access Manager post. But in the meantime, we are identifying those people that need training and making sure that they are provided with the relevant training. So it's not that people aren't getting the training. This is more about having a comprehensive forward-looking training program in place. So in line with our standard approach, we are carrying out harm reviews. We're in the process of doing that, and we'll report that to QAC. And just a couple of risks that we're flagging as well. So at the moment, we don't know exactly in totality how many patients we're going to end up adding to the waiting list. So there's still some data validation to be done, and it's particular in concern in relation to if we find any patients that have been waiting a long time, or a significant number of patients have been waiting a long time, we may need to put in additional resource to make sure those patients get treated quickly. And the other risk is around, at the moment, around the pathways we've identified so far that are open incorrectly on Lorenzo. So there's 40,000 pathways incorrectly open on Lorenzo that we need to close. That's too many to close manually. So we are working with the supplier of Lorenzo to see what they can do about automatically batch closing those. That's something I did in my previous trust. So hopefully technically it can be done and they can do it, but we don't have an answer to that yet. So that, again, flagging that as a risk. So in summary, we have issues with that, with the data quality of our waiting list. we'll have the new waiting list up and running by December. And in the meantime, we have processes in place to make sure we are ensuring all patients on the waiting list are visible and are being seen and treated in line with our normal processes. So hopefully that gives a good overview of what is quite a technical report, but happy to take any comments or questions.
Thanks very much, Hack. It is a very technical report, and sitting on audit committee, it took us a while to really understand the issue about it being a data quality issue. I want to just make one point, and then I will just ask both Simon and Sarah to just pop in. I will ask Laura if you want to say anything as well, but I just want to be clear that as far as the public are concerned, it is not that we don't have visibility of patients being referred to us. That is being picked up by a number of ways, and we are actually aware of all of the patients that have been referred and are working with them to actually refer them for treatment. That's correct, isn't it?
That's correct, yes.
Okay, thank you very much. Laura, do you want to say anything additional?
No, thank you. No, it's all covered, thanks.
Thank you. Simon and Sarah. Simon, it's been closely monitored through audit committee. Do you want to say anything? And then I'll bring Sarah in on harm reviews.
Not really, Julie, and I'm sorry, I'm having connection problems today. I think all the rain must be affecting my sound, but I think Hack has summarised it perfectly. As you say, it's well monitored through audit committee, and I'm very pleased that we're having this.
I know what Simon would be saying then, that we're being open and transparent in this discussion this afternoon. She's obviously having a problem. Sarah.
Thanks again. It's about echoing that honesty and transparency, and from a quality committee perspective, that's where we will be making sure that we're fully cited on the harm review process, and anything that needs to be escalated to us, we sought assurance at our last quality committee that would happen. So I think we are watching this in different forums, but are very aware. Thank you. Thanks for the summary, Hack.
Thanks, Sarah. Robin?
Yeah, just to follow up on that point, to confirm with Sarah that there's a paper to come forward to Quality Assurance Committee on the 22nd of October, which is the next meeting, to go through the detail there.
Thank you. Thanks very much. And thanks, Hack, for summarising what is a very technical, and Laura for the hard work, because I know this has been it's been something that's going on for a while, so thanks for all the hard work there as well. Thank you. Okay, into the governance section of the afternoon, we start with the BAF, or sorry, Business Assurance Board Assurance Framework and the Corporate Risk Register. Catherine.
Thank you, Julie. Well, hopefully the BAF makes sense in the light of the things that we've talked about, both in terms of our objectives and in terms of some of the other things we've talked about through the IPR and really all of the papers that we've considered so far today. I just want to highlight some things. So for members of the public, the board assurance framework is the risks to us achieving our objectives, which is why there's such a strong link back to our objectives. All of this has been reviewed by the relevant chief officer. And of course, both the BAF and the Corporate Risk Register have been through the Executive Risk Committee, and the BAF has been through QAC and through Anil as the lead NED for the Finance and Performance Executive. 3 risks on the BAF have been given partial assurance, and those are about reducing waiting times. And although we're making progress in some of our elective activity, our diagnostic activity, we aren't seeing a reduction in our waiting times in terms of the emergency department. Reducing bed occupancy, I think you've heard loud and clear that we're not where we want to be in terms of that, which is why that's got partial assurance. And then in terms of delivering our financial plan, that's moved from significant assurance in Q1 to partial assurance in Q2, because whilst the financial plan is broadly on track, as you've heard me say. The run rate is not, and we need a reduction in the run rate to meet our financial plan for the end of the year, and that's why we're providing partial assurance in this quarter. The risk scores have remained the same apart from embedding prevention, and that risk has reduced from 16 to 12 based on the significant progress against the actions in the quarter. And then moving on to the corporate risk register, because I think it's useful to take these two things together, you will see that our biggest risks in the organisation relate to the implementation of immediate ambulance handover in the emergency department, the link to reducing our bed occupancy due to and the resulting overcrowding in the emergency department. And then we've got a risk around some challenges in our ophthalmology pathways. We have closed one of the extreme risks relating to industrial action, and that's due to the junior doctors' industrial action being settled, although we note that the Royal College of Nursing have not accepted the recent pay award, so we wait with interest to see what is going to happen there. And then 2 new risks have been entered onto the corporate risk register. One is around the resourcing required for face fit testing, for mask fit testing for staff, and making sure we're in line with the requirements around that. And the second one is around the support from occupational health services, which are run through a service level agreement, but have an impact on our staff. So that's all I really want to say about both the BAF and the corporate risk register, but I'd be happy to take any questions.
Thanks, Catherine. Questions? For me, Catherine, I think you've said it a few to Sarah. I'll bring you in before I say something.
So it was really a bit of an anomaly sort of question or comment, really, based on BAF 4, which we've actually reduced down to a 12, which I'm really pleased about. Just with the prevention, I think as we've gone through our agenda, there's been a nod to prevention, and I think I'm very pleased to see that that we've really completed, or we're well on track with some of our actions there. I think I'm interested in that SO3, looking at directorates and their business cases and building prevention into all those things with our financial challenges and some of the pressing challenges around bed occupancy. I think just to raise really that's something that I will be keeping a focus on, that we don't lose sight on the prevention agenda, because we know that for every pound we invest in prevention, we will save far more in the future, but it's easy to get squeezed out. But really pleased to see that we are on track with that.
Thanks, Sarah. We look forward to your ongoing vigilance on that.
Thanks very much. And I do think it's an important point. These are the actions that we've taken that have reduced that risk in our BAF, but to actually make a real shift, we rely on other partners. So not to give any false reliance that we're making a huge shift to prevention. It's a much bigger matter that revolves around all of the system. I think for me, Catherine, I think we can take assurance about those areas that are actually where we've heard about their trajectory. I think they're the right ones, but we've heard today about the actions that we're taking and can take assurance from that. And I think it's right that the financial outturn has reduced this particular month. Okay, effectiveness review. Sarah.
Thanks, Julie. So I think this report's self-explanatory, is for the board to receive and note. The one area that was identified that remains ongoing for an area of improvement is around reducing the reports to Trust Board. I do think there has been a significant amount of work on that, and thanks to the execs and their teams, because the meeting books have reduced significantly. So, and I know that's been quite a challenge to reduce some of the reports. So thank you. Happy to take any questions.
And I think we've noted today certainly in a couple of areas, 2 or 3 areas, just how the reports have been pulled together more concisely. So thank you. Any other questions? My question, oh, sorry, Sarah.
I'm sorry, I just missed the opportunity really on the last paper, but it ties nicely with this, Sarah, just to say that I think that the board assurance framework and its links through with the corporate risk register and the way that it's now displayed makes that far easier to follow through. So I think appreciation, and both from the board, but also if any members of the public are looking at that, I think it's far easier to see what we're dealing with. So thank you.
I would totally agree. Thank you. A lot of work on that presentation. My one question, Sarah, would be about when will a further review happen?
I think we need to look at that to do that next year, because the NHS England guidance are every 3 to 5 years for external reviews. So I'm proposing next year that we start looking at that, and whether it's under the foundation group, so we can do the comparison against all of the trusts.
Okay, thanks very much.
Thank you.
Thank you. Ratified policies. This should be quite quick, Catherine.
Let's keep it brief, if that's our watchword. There were no policies that were went through the policy review group this month, so it's a nil return from me.
Thank you. Thanks very much. And we've got a couple of annual reports. First one, welcoming Kirsty, I think, if I can see her. Or is it you, Robin? So summary of combined health and safety, fire safety and waste management.
Hi, Julie.
I'm going to say, it should be Kirsty, Julie. Yeah.
Yeah, she's there.
Hi. Afternoon, everybody. I'm going to take it that the paper's read and just give some highlights and some key points in the report, if that's okay. So the annual report provides a summary of health and safety, fire safety and waste management issues that have arisen in the financial year 23-24. And the report includes data on compliance with health and safety legislation and includes details on the trust compliance with staff training, which for health and safety was 97% and for fire safety awareness 95%, which has been the best it's been for a very long time. So there are some incident statistics within the document, which highlights that there were 541 incidents, and that's a slight increase of 20 incidents on the previous reporting year, but the increase is proportional to the overall increase in hospital activity. And the top 3 incident types were verbal and physical abuse at 293 incidents, slips, trips and falls, there were 39, and dirty needle stick injuries, there were 42. There were 17 RIDDOR incidents, which were reported to the Health and Safety Executive, with the highest category again being slips, trips and falls. All of the information within the report has been monitored by the Health and Safety Committee, who review all of these incidents on a quarterly basis. The committee is very well attended by both directorate and corporate teams, and the committee works to identify themes and trends and actively works to reduce the number of incidents occurring in the future. In terms of fire safety, again, the report confirms that as a trust we continue to conform to the regulatory reform Fire Safety Order 2005, and we've maintained our close working relationship with Warwickshire Fire and Rescue Service, who during this reporting period undertook 3 site visits, one to Middlemarch House, Lewes House, Lucy Dean Renal Unit, and there were no major issues found. There were 2 confirmed fires, unfortunately, one of those in the chapel, which was caused by a tea light, and steps have been put in place so that that doesn't happen again. And the second one was a waste bin outside the main entrance, which was caused by an unextinguished cigarette. There are 108 unwanted fire calls, with the majority of them being caused by cooking, dust or steam. And the fire safety officer, just to note, he's very proactive and he's worked to reduce the number of fire alarm incidents, with annual risk assessments and action plans being put in place for each department. The addition of ward walkthroughs, which have been introduced in clinical areas, has greatly improved staff awareness of what to do in the event of fire. Also, the reporting of incidents has greatly improved. Face-to-face training commenced in 23-24 as well, which again goes a long way to ensuring that the training is site-specific and ensures compliance with the Regulatory Reform Act. And a number of new fire wardens have also been recruited, which again provides assurance that there are adequate numbers of trained staff in the event of a fire. And just a little bit on waste management. So all of the waste streams have increased across the site, with general and confidential waste increasing by 26 tonnes and clinical waste increasing by 18 tonnes. And again, this is all proportional to the increase in activity across the site. And the report also highlights that all of the waste duty of care audits were undertaken, and we have our regular waste contractors who do internal audits, and they are undertaken regularly over the 12-month reporting period. And there were 10 DATIX incidents relating to waste management, and they were all investigated and reviewed at the Health and Safety Committee. So that's it in a nutshell. So I'm happy to take any questions.
Thanks very much, Kirsty. Simon.
Can you hear me, Julie?
Can do. Yeah,
Yep.
you just froze at the very end. So if you speak quickly, we should be okay.
Okay, thank you. Thanks for the report, Kirsty. Very comprehensive. The verbal and physical abuse incidents look particularly concerning, and I just wonder, where do we monitor these throughout the year? I don't really recall seeing these figures in reports that I see.
So they're always reviewed at the Health and Safety Committee, but as part of the NHS contract that we have by April next year, there's the introduction of the violence reduction and prevention standards, which as a trust, we've got a small task and finish group that are applying those matrix. Now, one of those is that we've got to report regularly into the board. So I think that's on a quarterly or biannual basis. So you'll be hearing more about those going forward. So I hope that answers the question.
Thank you. Thanks, Mum. Any other questions? Robin?
Just to underline that point Kirsty just made, also goes through the health and safety as a regular report back to TMB as well. So those areas picked up through Trust Management Board, Simone.
Thank you. Okay, thanks, Kirsty. Nice to see you again.
Thank you.
And we've got Samara here for Controlled Drugs Annual Report. Over to you.
Hi, Julie. I'm going to mostly take the report as read. This report is my annual report as my statutory role of Controlled Drug Accountable Officer for the organisation. It has been through OBQSG and it has been through QAC as well. In terms of our controlled drug management and accountability, there's currently no risks on our risk register. We have given the report a significant assurance on our processes that are in place with some minor improvements, because we do have an ongoing action plan of the work we would want to be doing as the course of next year as well. There are a number of significant processes already in place, I would say, in terms of assurance that we utilise for triangulation internally, for any reporting we need to do externally as well, and any learning we need to bring from external, from NHS England or from our other counterparts in the system as well. Over the course of last year, there have been no serious concerns or issues of note that we've had to escalate externally. And as I said, for extra level of assurance for this group, it'll also be worth noting is that as despite all of the processes we have in place and the oversight we have through MSOC and external reviews as well, and the reporting we do undertake on a quarterly basis, I also keep an independent review of all of our incidents and all of the reporting that comes to me directly or comes through me via our incident data system as well, just to make sure that I can independently review and advise, as well as what our obviously service leads and areas would take into account as well. So that's part of my kind of management process, to make sure that I'm assured of our processes and there's no further escalation. So I think overall it's been a relatively steady year, and I'm hoping next year I can say the same thing as well. Lots of improvements that we've continued on, changes to our policy to bring some of the new legal guidelines, etc., into place. But there's been nothing really of undue concern or noting that this group may want to be cited on, but happy to take any questions.
Thanks very much, Samara. It's good to hear about that independent management process as well. That's really good to hear. Questions, observations? Happy to receive and note this report. Nudge, then Jackie.
Yeah, thanks, Samara. And just to add to what Samara said, so I mean, the discussions at start, it's that ward to board format. So we started at Medicine, Safety and Optimisation Committee, good robust discussion with the directorates and the teams who attend there. And then those reports are brought up to the board. But yeah, very robust. So we discuss all the incidents, the audits, and where improvements can be made and where learning can be shared in any incident that's discussed there. So that's sort of assurance for the board.
Thank you. Thanks, Nudge. Jackie.
Thank you. Thank you, Samara, for the detailed report. I did have a question regarding the drugs that CDs brought in by patients, and we seem to have some issues around their management. Have we looked at our procedures around this? Because obviously it's a fairly high risk area for us.
Yeah, I think we picked it up from our reporting and the review, as Nadia said, under MSOP when we review our incidents and trends. So there've been a number of ways of we've tried to tackle, and so a lot of that has been about education and training of our staff and making sure all our staff are familiar. So we have very robust written SOPs, and our CD policy covers lots of legal and governance frameworks and what we need to operate from. But a lot of that is the application on the local level and how we disseminate that information. So there is a piece of work that are done under MSOC around how we bring our corporate nursing team along, how we bring our medication safety officer along to that for training events. So we've done lots of ad hoc interactions and planned training events as well. The other thing that I would say we probably focus on and pick up on as well is there's a pharmacy team that's now embedded into each of so they have a direct link with their own technician and pharmacist they can ring regarding CD related concerns, issues, if they got returns to do whatever management support they need in terms of CDs as well. So we got that in place. And again, under MSOC, as we discussed this, we also have our education and training preceptorship team as part of that committee. So what they would look at is actually, is there things we can add into training packages? Is there things we can add into preceptorship, and we do it one-to-one? Are there trends that we coming forward? And we do it with all medicines, not just this. So they've been quite keen to kind of help along with this as well, and we're picking that up. The new training package is being revisited that as well for medication safety holistically. So we then start focusing on some of our trends and themes in there as well. So I'm sure this will come as part of those trends and themes too.
That's great. Thanks, Samara.
Thank you. Thanks very much for that. And I think we're happy to receive a note. Thank you. Can I just go back to Simon's point, because I'm not sure I quite heard about consistency of monitoring and reporting. So Samara, you said about the monitoring and then that this goes through to QAC. I think I heard, Robin, that in terms of health and safety, it goes through TMB rather than QAC. I don't know whether that was part of your question there, Simon, is that's given well, all things are important, but it's not something I'm usually familiar with. It would go through an assurance committee, health and safety. Simon, were you making that point, or have I missed the point you were making
about the incidents? Yeah. I was making the point that as a board member, I don't see that data regularly. So hearing that it goes through QAC and TMB, and then the assurances that we heard from Kirsty about what's coming down track, made me feel assured.
Okay, but generally health and safety doesn't go through QAC in the same way as controlled drugs do. Okay. Can we have a think about that? Robin's saying, yes, we can have a think. And Catherine's saying we can have a think. Can we go away and have a think about that?
We can go away and have a think about it. I think what the point I would make is the reason why Health and Safety Committee reports usually in most organisations through TMB route is because it covers quite a breadth of areas,
yeah, breadth of
areas that QAC wouldn't really be wouldn't be appropriate to take everything through QAC. Therefore, the way in which it's set up is that those areas that do need to go through, they're filtered out, as Kirsty identified earlier. So happily, I'll talk it through with Catherine and look how we do that in the structure outside of board.
Yeah, it's just in that governance structure, because our structure is different ones that I'm familiar with as well. So just to making sure that governance structure picks that up. Thank you.
Catherine and I'll pick that up outside.
Okay, thank you very much. So thanks to Kirsty and to Samara. So we're going into supporting information now. A couple of subcommittee chairs updates. Firstly, Sarah and then Simon. Oh, and also Catherine, I assume, for Improvement Board. Yeah. So Sarah, anything you want to raise that we haven't talked about that you want to draw to attention?
I think we've talked about most of the things that have gone through quality assurance. Probably the only thing just to draw your attention to is in the paper, the major actions commissioned and work underway. You'll just see at the bottom there, we are keeping a focus on sepsis and deteriorating patients, and that has got several avenues where a focus is still being kept there. As a committee, we've got partial assurance based on the quality of information that we received. And you can see there some of the positive assurances provided as well.
Thank you. I really like these reports. Thought they look really good. Thank you for that, Sarah. Simon?
So I wasn't able to be at audit committee this time, so Anil chaired, and as you can see from the update report, very ably and capably. And the key thing that needed to be discussed was the compliance with the national cleaning standards, and there's a piece of work being commissioned around that. But similarly to QAG, a lot of positive assurances provided there from this meeting. I don't have anything else to add, but I'm happy to take questions.
Okay, thank you. Any questions of both Sarah and Simon? No, thank you for the work of the committees, and we move on to the Improvement Committee.
Thanks, Julie. Well, the one thing we haven't touched on anywhere in the agenda today, which we looked at the Improvement Board, was about the improvements in theatre productivity, the 17% increase in total uncapped theatre utilisation and the 19% increase in capped theatre utilisation now puts George Eliot on this set of data at the 6th highest in the country for the uncapped utilisation. And that's been really a difficult metric to improve. This is down to the work of the theatre teams, the surgical teams. And what was so encouraging to hear in this was about the way this was being driven by our staff and led by them. And thanks to all the people who've supported the culture change that's enabled that to happen. So that's really the only thing I wanted to particularly highlight from the Improvement Board, Julie, that we haven't already touched on today.
Thank you. Thanks very much. Any questions around the Improvement Board? No, thank you. And then we just need for information to note the minutes of the Quality Assurance Committee on the 27th of August and Audit Committee on the 30th of July. We're coming to the end of our board this afternoon. Is there any other business from anyone? It's an opportunity to ask any members of the public observing if they want to ask questions of us around our board meeting this afternoon. David, hello.
Oh, good afternoon, everyone. Chair, can I just say on behalf of the public and patients, the strong statement you made, reassuring the people that the Lorenzo issue on numbers on the waiting list, no one has been lost to the GH system, and that patients can be reassured of this. If you could restate that, I'd very much appreciate it, Chair.
Absolutely. I'm going to ask Catherine, so I make sure I say the absolute right things in terms of giving that assurance that nobody has been lost, Catherine.
Yeah, and David, that's a really important point to highlight, because that's what we worry about. If we're not convinced that the data's right. So we have used different mechanisms in order to make sure that the teams that treat and track our patients have got visibility of all the patients on our waiting list. And the work that we are doing now is to make sure that we can measure that through the data, as well as having additional systems and additional support. So no, we're not aware of anybody that has been missed off the list, and we are confident that the patients are being tracked who need to be treated.
Thank you very much, everyone.
Is that okay, David?
Yes, I think that will reach all the corners that it needs to reach.
Thank you. Any other questions? Then I will bring this meeting to a close. The next meeting on the 6th of November is a Foundation Group Boards meeting. Our next GEH Public Board meeting is on the 3rd of December at 2 o'clock by Teams. I'd like to say thank you very much to everybody. For colleagues who are going into our next meeting, Sarah, do you think it would be possible to bring Dan and Joe, I think it is, a bit earlier?
They are on standby for.
Okay.
Yeah.
Okay, so if we were to just give ourselves 10 minutes, so if we get together at 15:50. Thank you very much, and I'll see you in a little while. Thank you.